Good afternoon, everybody. My name is Kevin Conlon, and it's a pleasure for me to introduce the Johnson & Johnson Lecture. RCSI is proud to partner with Johnson & Johnson as we work collaboratively in supporting healthcare education and training, and we're very grateful for the continued support of Johnson & Johnson in this endeavour. We're delighted to welcome colleagues from Johnson & Johnson today, including Shane Collins, who is the Strategic Capabilities Lead for J&J. The 2025 J&J lecture will be delivered by Dr. Carla Pugh. I'm going to have to try to summarize an absolutely amazing curriculum vitae. I had the pleasure last night of going through 92 pages of her curriculum vitae, and it is absolutely superlative. She currently is the Thomas Crummell Professor of Surgery at Stanford University School of Medicine and the Director of the Technology-Enabled Clinical Improvement Center. She obtained her undergraduate degree in UC Berkeley in neurobiology, and then subsequently her medical degree at Howard University School of Medicine in DC. Upon completion of her surgical training, which occurred at Howard University Hospital, she went to Stanford University and obtained a PhD in university, and in so doing became the first surgeon in the United States to obtain a PhD in education. Following spells in Northwestern University Freiburg School of Medicine and the University of Wisconsin, she rejoined Stanford University in 2018. Her clinical expertise is in acute care surgery. She is considered a leading international expert on the use of sensors and motion tracking technologies for clinical performance measurement. Her current research involves the use of simulation, advanced engineering technologies, and artificial intelligence to develop new approaches for assessing and defining mastery in clinical surgery. She is widely published with in excess of 180 peer-reviewed publications. She is currently the principal investigator in 8 active grants, including many NIH grants, and has won numerous awards. Too many to mention all of them here, but to highlight, she was awarded the Presidential Early Career Award for Science and Engineers from President Obama in 2011. She was inducted into the American Institute for Medical and Biological Engineering in 2018, the American College of Surgeons Academy of Master Surgical Educators in 2019, and more recently, she was awarded from the Society of University Surgeons the Trailblazer Award in 2023. And she was elected into really prestigious National Academy of Medicine in the United States in 2021. So I am delighted and honored to invite Dr. Pugh to the podium and look forward to her Johnson & Johnson lecture, where she will address precision learning and data sharing through wearable technology. What's AI got to do with it? Dr. Pugh.
Well, thank you very much for your kind introduction, and I am just ecstatic to have been invited to give this lecture. It is a huge honor. Your wonderful president here, Dr. McNamara, we met many years ago, and we're receiving an award from the Association of Women Surgeons at the same time, so we had a grand opportunity to get to know each other and stay in touch. I'm also grateful for Johnson & Johnson for sponsoring this lecture, and I look forward to sharing what I've been up to with numerous colleagues and friends in this space. So what if we had access to continuous data streams from the operating room? Could we develop a new data-driven certification program targeting procedural care and processes? These are my disclosures. I've been at this for quite some time, and when there are things that you want to do and they don't exist, you invent them. My agenda here is to share a little bit about the wearable technology and the concept of the quantified self, which inspired some of this work. And I'll share specifically, we've used a wide variety of wearable sensors, but this lecture is mainly focused on audio, video, EEG, and motion data. And then I'll talk a little bit about advances in AI and what the opportunity is for us as surgeons and clinicians to be part of this massive change in our ability to handle data. So the quantified self really is relating to the Fitbit era. How many Fitbit or watch or people tracking your sleep and your heart? There we go, a number. It became the norm and has expanded to looking at your golf swing and getting metrics. And obviously we know there's no metrics, no Olympics. How do you know who's a gold medalist if you don't have measures? And so we started exploring this concept of the quantified surgeon in the simulation arena. And again, as I mentioned, we've looked at audio data, video data, EEG data, and motion tracking. And the interesting and fun thing about this is that there is an opportunity to capture multiple video streams in EEG and motion. So this is applicable not only to the surgeon, but the assistant, the scrub tech, the medical student, anesthesiologist, the circulator, whomever is in the room. So there's a real opportunity here. One of the papers that we published relating to audio data was on a study that we had with second-year residents where we exposed them to a simulation that required them to make a decision. So they came into an operating room, a procedure had already started. This was the simulation scenario. And they were assisting, and then a problem occurred. And so we recorded how they talked through the problem. They didn't know the problem was going to happen. And what we learned and this ironically was well before ChatGTP, we collaborated with a researcher in the education space who did what's called epistemic network analysis, which is really sort of the mathematical work that goes into ChatGTP now, many years later. And what we were able to find was that how the residents talked through the unexpected event predicted and correlated with the outcome of the procedure, how quickly they were able to address the problem, or if they weren't able to address it at all. And this was more, the gist of it was if you use team language and you verbalize everything that you are seeing and what you're thinking and you're struggling with, then you enable those in the room to partner with you. Otherwise, if you're alone and trying to figure this out, which many times we are alone, but you don't verbalize it, it does not enable the team to help. They don't go and get additional instruments. They don't anticipate. They don't retract differently for you. And so it's just an interesting phenomenon that what you say and how you talk to your team predicts how you address or not a unexpected event in the operating room. This one was interesting with video data, and I'll share a bit more, but this was a particular study that my colleague and I performed with a company that is using artificial intelligence to analyze videos of thousands of laparoscopic cholecystectomy procedures. And we predicted that AI would fail when there was more complex anatomy. We looked at this database. AI had already categorized whether the critical view of safety had been achieved or not. And then we had our surgeons, in a blinded fashion, put their own ratings of whether they believed the critical view of safety had occurred or not. We separated the various gallbladder procedures using the Parkland scale from those that were sort of normal appearing gallbladders, likely due to biliary duct obstruction or biliary colic as opposed to an infection, and then grade 5. And there's 1 through 5. And so the procedures were rated that way. And again, we predicted that at least grade 3 through 5 AI would likely be less accurate. Turns out we were wrong. What was interesting is that AI was trained to identify an image similar to this as the critical view of safety. And that means that you have only two structures going to the gallbladder. You have a view of the cystic plate at the liver and the hepatocystic triangle. And it turns out that AI actually predicted that the easy gallbladders was interesting. Surgeons take shortcuts, and if they leave just a little bit of fat on an artery or a duct, then AI would say that you did not achieve the critical view of safety. But the surgeon said, yes, that's clearly, that's clearly two structures. So this was pretty interesting in that it depends on how you train AI, but also just to note that surgeons, when the anatomy is difficult, we tend to skeletonize those vessels to really make sure. When the anatomy is pretty straightforward, we take shortcuts, and AI doesn't understand why we do that. So just something to know when we are using these algorithms, not making judgments of surgeons, we really have to partner. There's still human in the loop such that the human understands what humans do more than you can train a computer. This is an image of me in the operating room with an EEG. And I took this picture, I shared this one because I think it's funny. This is an EEG sensor. It's a foam sticker, and I wore it the entire day across open and laparoscopic procedures, and I forgot that I had it on because it's so light, and when I was in the cafeteria, everyone wondered if I had a fever. They thought it was a temperature probe. And others ask, well, how can you wear that throughout the case? Isn't it annoying? And I'm like, this is a really great picture. Guess how much that headlamp weighs compared to my EEG? I didn't remember that I had it on. But this is the data. This is what my brain looks like during an appendectomy. Maybe scary, but I think that's a beautiful brain. So what you're looking at, the red areas are when I am visually focused on what the resident is doing or verbally communicating. And there's a pattern there. The red areas are me instructing. The darkest red areas are at the point of a major decision in terms of clipping the mesentery for the appendix, and then the actual appendix at the base of the cecum. Then the next longer area of red is hemostasis. And that just makes sense. I'm watching to make sure that this, before you close the abdomen, and then you see my brain, the heat map changes. Similar pattern with the cholecystectomy. Different amount of time between clipping the cystic artery in the duct, and then that period of hemostasis in the end, just before the procedure ends. This one actually shows real-time EEG data, just to show you the power of this data in terms of helping us. When you synchronize video and EEG data, it's a huge opportunity to really understand what's happening. So this is a simulated laparoscopic ventral hernia repair, and this is you see on the top the external camera, a surgery resident, and the assistant. On the bottom camera is the endoscopic view, and this one has the red dots represent the hernia defects. So this is the Swiss cheese effect when you get defects after a prior operation. And I will show you in the graph that represents focus, this area outlined between the two red bars is when the surgical resident is partnering with their assistant to prepare the mesh outside of the abdomen. And you'll note that they are verbally communicating and placing sutures. And so there is both verbal action, planning, and communicating happening. And this is a very different EEG waveform than when the mesh goes in the abdomen and now the surgeon is operating by themselves. And you'll see it as I'll play the video and watch the bottom screen when that amplitude of the EEG signal changes. Lots of coordinating there. Turn the mesh this way, making sure you don't stick someone while you're putting those sutures in the mesh. And there you go. So if you ask the surgeon to say, what's your cognitive load and how does it change throughout a case? We can't do that. There's so many opportunities here, I think, from a learning perspective. Surgeons can maintain high levels of cognitive load and function well. However, when things aren't going well, there's a limit to what you can address over time. And so there's times when it's okay to ask something that has nothing to do with the operation or bring another problem in, because we're always multitasking, and sometimes it goes well and sometimes it doesn't. And we now are able to track that and the reasons why, as well as there's lots here with this data with the EEG. We've noticed that when you have multiple EEG signals, the surgeon, the lead surgeon, a trainee, it turns out that the lead surgeon has higher focus when they are watching a resident operate, but less enjoyment. Lots of things that we can learn. I'll move on here to the motion tracking, and these two videos are interesting, I'll tell you. The novice knot tying is actually really not a true novice, but a plastic surgery fellow, and the expert is a 20-year veteran. And I will show you the video of the fellow's suturing, and this is a simulated microvascular anastomosis. They make a mistake in the very beginning. Two things. One, they're sewing away from themselves. They start closer with the first stitch in that anastomosis. And if you look closely, you see a little bit of a fine tremor. They also pulled their tying suture tail long outside of the view of the microscope. And sometimes we do this as experienced surgeons, but usually we'll cut it because we don't accept inferior circumstances, but novices do, and that affects their efficiency. The other thing you notice is that the surgeon with more experience is moving slower. And that is because we want to get it right the first time. So if you look at all of the motion tracking data that we have, many times you'll see that the surgeons, master surgeons, will slow down when it counts. We learned from the fellows after looking at a lot of this data that they operate really quickly because they don't want us to take over the case. But they end up doing lots of redos because haste makes waste. And if you had to give this fellow feedback, they probably would not listen because the suture looks great, the knot looks great. But when you show them their motion data, they now realize that they can improve. This motion data is plotted in terms of percent completion. So the blue, the darker blue area is the first throw for the knot tie. And you can see when you look at the expert knot tie, because the suture is a little longer, once you tie that first knot, the suture shortens, then your working volume, each subsequent knot, there's less motion and a smaller working volume. When you look at the fellow, now they actually have a visual performance criterion that they can meet, and they realize now that they are less efficient. But trying to explain that to them when the suture looks great, they can't hear you. This is not a technical issue. This is a rule-based error. And a rule in terms of pulling out that suture tail, and now you've got to spend all that time in working volume chasing that suture tail under the microscope. That's the real lesson there. So we've used motion metrics a number of different ways, not only to look at technical skill, cognitive skill, which unfortunately I won't have time to talk about today, but there is a correlation between your movements or lack of movement and what shows up on your EEG. So there is some relationship between the motion and the cognitive load that happens with motor control compared to cognitive load that happens with visual inputs and communication. So there's a lot to dissect here. I will talk about mastery and give one example here. The Surgical Metrics Project is a collaboration between my research lab and the American College of Surgeons. And in 2019, this was the first time that we brought wearable technologies to the clinical congress, and we had hundreds of surgeons wear the wearable technologies. And partnered with the executive director of the college at that time, which was David Hoyt. And his interest was really, introducing digital healthcare and getting surgeons to be involved. And this talk, as I mentioned to some of you who I've spoken to before the lecture, this is really a call to action. We as surgeons have to be at the table because we are the only ones that understand what this data really means. There's early insight that industry and simulation companies and other groups can understand from the data. But if we're not at the table, there are going to be key decisions that get made regarding the meaning and usefulness of the data without our control, and that will be dangerous. So this is the exhibit hall setup, and again, hundreds of surgeons came. The scenario that we presented to them was a 1.5 feet of porcine intestines with 2 enterotomies. We told them that they had just completed a 2-hour lysis of adhesions and they were running the bowel looking for enterotomies. We did not tell them whether there were any or how many there were. And we put 2 enterotomies, a small one next to a larger one, because we wanted to see how many would make the decision to cut the tissue in between and do 1 repair and how many would do 2 separate repairs. So we really wanted to understand, if you look at hundreds of experienced surgeons, what is the wide range of decisions they would make if they were all faced with the exact same scenario. And this is what the bowel looked like. So this is the analysis of our video results. We had over 250 participants. We did exclude for this specific analysis a number of participants. Some people missed one of the lesions, like they didn't see the second one. Most of them missed the small lesion. We did have one person who didn't wear their glasses and they found the small one, but not the large one. That was confusing. But it's a simulation. And so when we were looking at the endpoint of a bowel leak, those who missed a lesion, that's a different mechanism of a leak than those who purposefully repaired and still leaked. So we wanted to look at those who purposefully repaired both of the lesions. And these were the results. So of those who found both, it turned out for those who repaired, cut the tissue in between and repaired the injuries together, they actually had a significantly lower leak rate than those who repaired the injuries individually. Then of those who repaired them individually, there was those who did a single layer and some who did a double layer. Those who did a double layer also had a lower leak rate. And there's some commentary whether you really need to do a double layer for, an enterotomy, but it depends on the bowel and also the sutures that you put in, whether you liked your repair or not. It turned out that there was no difference between running and interrupted from the leak rate. However, if you did an interrupted repair and did not place the corner stitches, you were more likely to get a leak. What's interesting is that you can be on the riskiest pathway towards a leak, and it turns out that only 50% of people leaked. So who are these people who take the risky pathway and still do well? And it turns out that those persons placed 1.5 times more suture in that 2-centimeter rent in the bowel, and they also assisted themselves. So there's something to this bimanual dexterity that keeps coming up, and we've talked about it from an engineering standpoint, but this keeps showing up regardless of the procedures that we study, and we believe that it has to do with cognitive load in your training, and really we named it, those are the Jedi Masters, that you are one with your suture and the procedure, and your operative planning and everything, you have more time to really assess the tissues and how they're responding, and you make different decisions. So we published this study and really raised the question to the audience, what is your requirement for the number of sutures? We all have it in our head. We never verbalize it, but we use it to usher the residents around. We're like, no, put the stitch here. And we're just, okay, do that a little closer. And we give them this feedback, but what we're really doing is trying to get them to put the sutures in an order and fashion and level of closeness that matches the visual we have in our mind. And we've never verbalized it, we've never drawn it, and it's not in any textbooks, but this is one of our unconscious decisions. And these have been untested. So this was the very first time that there was a structured test of a leak after a purposeful repair. And I have to be clear, this is not really a true post-operative leak that puts the patient at risk. This is the leak that happens on the table, because we all do these repair and then we squeeze the bowel to see if air comes out, and if it does, then we put another stitch. We didn't allow these surgeons to do that protocol because we really wanted the larger numbers to see how many, we really wanted to map the decision. And again, those 4 technical decisions panned out. But very interesting for us, our summary was that individual preferences can be quantified and were shown to have measurable effects on procedural outcomes. It was just a preference whether you cut that tissue in between, whether you do running or interrupted, or whether you do a double layer or anchoring sutures or not. This is not technical skills. Everyone here knew how to sew. These are technical decisions that likely stem from your training and your own personal ways of doing things. And so that does make a difference. And that is an area that keeps the mystery within surgery in terms of outcomes. So what does AI have to do with any of this? I have presented a wide variety of data streams, and that's the opportunity. Human assessment of these data streams independently can give many insights, and even if you put them all into a logistic regression in a linear fashion, you'll find some relationships. However, AI has the ability not only to make this more efficient, but to look at things in a non-linear fashion and at complexities that we're not able to do with standard statistics. AI has gained significant popularity as a tool to analyze surgical videos, and a number of you are familiar with some of the tool recognition algorithms, as well as sequencing and predictive validity of some of these algorithms, and knowing what is the next step, predictive step in the operation, and how much time you spent in each of the segments and critical decisions, and then being able to give comparative feedback relating to that. What is interesting, we have been doing some of those algorithms, the AI algorithms, for over the past 15 years. In the past 2 years, there are now algorithms, and this one happens to be by Meta, one of our favorite companies. If you think about it, anything that you have on your cell phone, anything that you post online, whether it's YouTube, any video that you take of a case in the operating room, they all have our data. And they are training their AI algorithms on video data and images. And the first wave was still image. But now that they have video, they can track a human being, a dog, a surgical instrument very easily in a nanosecond. And so now all of those annotations that we were doing, where surgeons tagging the instruments and needing thousands of videos, these companies have this data now, and they now can segment anything model. They can segment any operative video according to the number of instruments, the bleeding. They can recognize blood. They recognize anything because they've got all of our data together in one place. I'll go through this one quickly. Just reviewing the benefit of AI. This is again, the same study where we worked with a company that had thousands of videos, and you can see how they segment. You can actually just click on the link on the right side and go directly to a specific segment of an operation. And this is what we used with the surgeons who did that analysis of whether the critical view of safety had been achieved. And what we realized as we were doing our validation of the review of the surgeon's indication of the critical view of safety or not, my colleague and I were amazed. We were able to review 50 lap chole videos in an hour. And that's because we clicked on the point just before they were placing clips on the duct or the artery. And in that moment, we realized the benefit. Surgeons in training, second and third year residents, never get to see this. It takes them 2 to 3 years to be able to compare that anatomy, and it's not focused because they do a gallbladder, then they do an appendectomy, then they do a bowel obstruction, and they're getting different bits of information and anatomy and critical decisions in the abdomen in the human body. But if you look at 50 lab chole videos in an hour at that critical decision-making point and see the variation in anatomy, the first thing we realized was that many times you cannot achieve the critical view of safety because the artery doesn't allow you to. And in that moment, you are off the beaten path, and then the surgeon is making different decisions than they normally would in other gallbladders when the anatomy is the same. And so to be able to see a wide variety of anatomical variations and the decisions that were made in that moment, that's when we realized the value of AI, because nobody wants to watch 50 one-hour videos. It's not possible or desirable. So the opportunity here is huge in terms of shortening the learning curve to mastery, to competency, and really achieving the best surgical outcomes with respect to any of the data from patient anatomy and disease, team coordination, data visualization, and many studies have shown that after you have finished your training in surgery, that you continue to improve your operative times and blood loss over the course of your career. And this is because you are getting your own insight, your own feedback. But think about it. What if you had 50 videos of your index procedure before you did these? You would take the lessons that you've learned from your colleagues and you'd see those decisions. This is the opportunity for everyday use, for information exchange, and getting us on the shortened path to higher quality in our profession. These are the various research teams throughout my career that have helped to make this research possible. None of this is done alone or in isolation. And so I thank my team and I thank you all for the opportunity to share some of my work.